All right, we
All
are
right, we
live.
are
Good
live.
evening,
Good
everybody.
evening,
This is
everybody.
Dr.
This is
Michael
Dr. Michael
K. from the
K.
Center
from
for
the Center
Functional
for
Health,
Functional Health,
and honored to
and
have with
honored to
me
have with
tonight
me tonight
Pamela Moore of
Pamela Moore of
Stream
Stream
Counseling.
Counseling.
Pamela, welcome.
Pamela, welcome.
Thank you so much thank you for having me. Excited to talk a little bit more about my areas of expertise.
Excellent. So
Excellent.
last
So
week I had
last
a
week I
chance
had
to
a
speak
chance to
with
speak
one of your
with one of
coworkers,
your coworkers,
Jesse, and I get
Jesse,
to
and
speak
I
with
get to speak
you.
with you.
And tonight
And
we're
tonight
going to
we're
go
going to
over
go over
eating
eating
disorder.
disorder.
We'll talk
We'll
about
talk about
body image
body
issues,
image issues,
anxiety,
anxiety,
and
and
how
how
traumatizing to all
traumatizing
this as
all
well.
this as well.
Yes.
So before
So
we
before we
begin,
begin,
I love to
I
hear the
love to
hero's
hear the
journey.
hero's
So
journey. So
how did you get
how
here?
did you
How
get
did
here?
you
How
choose
did
this
you choose this
profession?
profession?
And
And
what does your
what does your
certifications mean?
certifications mean?
Yeah. So, basically, I grew up in a family of a lot of medical professionals. So, my mom was a nurse, my aunt was a nurse, my grandma was a nurse. So, I was always thinking as a child, okay, well, that's where I want to be. I want to help people. And that was just the first sort of taste of being in the medical field and what that would look like. And then through time, I kind of found myself being put in this role of the listener in the friend group. And people would turn to me and say, you're a great listener. I'm having this problem. Can you assist me with this, or can you just listen? And so through time, that interest in helping people evolved from, okay, I definitely want to be in the medical field to, well, wait a second, what is psychology? What is, being a therapist, being a counselor? So through high school, I sort of explored that area, and decided that, I really would prefer to go the route of psychology, and being a therapist. Um, had some life experiences too that I think just confirmed that that's what I wanted to do in terms of, um, I have a brother who has dealt with addiction issues, for much of his, I would say, much of his teen to adult life. And so while he was going through those things, I was in that area where I'm like, what do I want to do with my life? And so, seeing how others would work with him, I really got the sense of, I think I could do this. I think this is something that, I think that I could be good at, and I think that I can help people. So that really reinforced the interest, and then it just sort of took off from there. Went to school for psychology, immediately went for my master's and my license afterward, with, the ideal being I would love to be in private practice, at some point, working with individuals who, um, are struggling with a whole host of different issues, which is where I've come to learn that anxiety, eating disorders, um, and other areas related to those, and trauma, because those all really fit together. That's really where I found my interest to be.
Gotcha. And
Gotcha.
the
And the
certified
certified
clinical trauma
clinical trauma
profession.
profession.
Can you talk a
Yeah.
Can
little
you
bit
talk a
more
little
about
bit
that?
more about that?
Yeah, absolutely. So that was something that I felt like was crucial based on my experience, professionally. So professionally, I've been all over. So I started off my career working with kids, actually, working in a wraparound system with kids with behavioral issues or autism or things of that nature. I moved from there to do some outpatient work, for a nonprofit organization. And then I moved to a residential eating disorder facility. So, um, as I moved through my professions, there was one thing in common, was trauma. I'm seeing individuals in all areas of life. I saw kids that were currently, in traumatic environments. I was dealing with women in an eating disorder facility who, 70 probably to 80% of them, were there, and had histories of trauma. So to me, it was a must. It was something like, I want to further my education in this area because this is what I'm seeing across the board with individuals. And I really just wanted to have that additional layer of expertise in terms of, how do I talk to people about this? What are some skills, that I can take from this to work with my clients in the future?
So when
So
we talk
when we
about
talk about
trauma, though,
trauma,
can
though,
you
can
talk
you
about
talk about
what
what
trauma is? Because
trauma
some
is? Because some
people
people
may not have
may not
realized
have
that
realized
they've
that
actually
they've actually
experienced trauma.
experienced
Oh,
trauma.
that's
Oh,
just the
that's just
norm,
the
right?
norm, right?
Everybody
Yeah.
went through
Everybody
it.
went through it.
That's
No,
that's just the way
that's just the way
parents were
parents
back
were
then,
back then,
right?
Yeah.
So
right?
I
So
think
I think
trauma happens, but people don't recognize, well, that was traumatic. So can you share some examples of what may be overlooked as trauma?
Yeah, and I think that's a great point because, I also think in society there's this big push to be quote strong, right? To face your adversities, to get through it, and I think male, female, I think, that message is out there of like, you just deal with the things that happen to you and you just get through it and you don't need to necessarily seek help or you don't need to do these things or harp on it. Um, but that we know that that's not the case, right? So, we refer to trauma, there's big T. So for trauma, there's big T trauma and then there's little t trauma, right? So when I'm talking about that, big T traumas might be those events that most people think of as traumatic. So, being sexually assaulted, witnessing, some sort of brutal event, those are things that I think the majority of people would consider traumatic situations. But we also have to realize that, trauma is individualized to the person. So, something that John Smith might think is not traumatic or to him is not traumatic might be a totally different scenario for someone else, like bullying, for example. Some people can, don't necessarily consider that traumatic, but other people that affects them for the rest of their lives and leads to all sorts of other, you know, um, issues with self esteem and all of that stuff moving forward. So I think it's important that, you know, we don't just look at the big T trauma events. Like we need to know the person, um, and we need to be able to talk with them and say, like nothing is too small, to be considered a trauma. And I think that's what we try to do in therapy is say, like, we're not judging you. We're not saying, your trauma is a 1 on the scale of 1 to 10. If for you it feels real, and you have some sort of reaction to it, then that's trauma.
So do we run the risk then of someone being easily traumatized by just simple things? Like sometimes life isn't easy. Life isn't easy at all, right? So life can
Right.
be very hard. So if we say, "Oh my God, you had trauma, you had this," and you kind of overexert, like it's too much for you, you can't handle this, you're not strong enough. You run the risk of making somebody, for lack of a better term, weak and unable to handle what happens in life.
Yeah. 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 And I think, and the key there is, what is their reaction to it? When we're talking about trauma, there needs to be some type of reaction that the body has, reaction that your mind has that is causing you to feel stuck there, if that makes sense.
Mhm.
Right. So, the event, even if it's relatively minor, again, it's a small T trauma. Like if that person's experiencing hypervigilance, there's some paranoia involved, or there's, things that have manifested physically, then we're looking at, okay, well, then that is actually a traumatic situation for that person. So I think you have to look at, how is that person affected, because as we know, like trauma does live in the body, like the body remembers these things, and it obviously affects our minds as well, because there's different symptoms that we get there. So I think we need to look at, like if this is trauma, then it is definitely affecting you in some way, mentally, physically, emotionally. There has to be something there. If those things aren't there, okay, then maybe we work with that and say, that was a distressing event for you, and deal with it in that term rather than a trauma term.
So in my world, we often talk about immune resilience, right? So can we build trauma resilience?
Yeah, yeah, and I think that's what really is the goal working with any trauma is, depending on, again, what the traumatic event was. Like we don't want people to think, well, oh, I can go through that huge big trauma again. But it's like, let me learn the skills that the skills that I need to get through that trauma. And like, can I then translate those skills to other distressing events that happen to me?
So it's learning a skill set, basically.
Yeah, absolutely. Yeah, I think it's a skill set. It's a an awareness of your body. It's an awareness of the symptoms that you're experiencing.
So in our world, treating a lot of gastrointestinal dysfunction patients, we see that anxiety can set the gut off. Mm. When under a good amount of stress, there's this gut-brain axis, and that becomes involved. And the irritable bowel is more than just diarrhea or constipation. It's so anxiety and stress driven. We often give the example that someone is so nervous to speak, and they have to run to the bathroom. It's not really a gastrointestinal problem, it's really coming from the brain.
Yeah.
So when we talk about trauma, can we talk a little bit about how the brain is involved in treatment?
Yeah. Yeah. Trauma basically like it takes over the brain. So there's something called like the fear circuitry, basically. So what happens with traumas a lot of the time is your prefrontal cortex, that's in charge of making decisions, executing, stuff like that. Basically, this fear circuit sort of interferes with that ability for that prefrontal cortex to work the way it's supposed to be. And that's why you may hear that people freeze, during trauma or, the fight or flight. Like that's a real thing that occurs during trauma. And a lot of the times we've heard more recently about sort of this freeze response. So what's happening here is, you've got this fear response taking over your ability to almost take action, make logical decisions, kind of get through that situation like you would in any other normal task where you're trying to solve a problem. Um, and then when this happens, it's taking its toll on the brain. And it's if you think about repetitive behavior, the more times you feel this way, the more times this tends to take over the necessary things in your brain don't function. It kind of becomes ingrained. You know, it um, the more times this happens, your brain starts to adjust to that. So that's why people talk about the fact that trauma changes the brain because it actually does. Um, your prefrontal cortex is not operating the way that it normally should. And instead, fear is almost covering it up and taking it over.
And in the beginning, we talked a little bit about addiction. That your brother had
Yeah.
addiction. My sister also had addiction. So when you look at a family unit, why is it that one sibling goes one way and sibling goes another way?
Yeah. Yeah. It's fascinating. I think a lot of it, like, what is that person's support system? Are they seeking help? Addiction is so genetic, and my brother's not the only one in the family, that has had addiction issues. So, there is a history there. And I think it's like I said, are you recognizing it to be a problem and what are you doing in terms of action from there, right? Um, he got so deep into it that it was, you know, and he never got help for it. There was never a time where he sought help for it. He also didn't seem to have a great support system in terms of people telling him, you need to do this, we care about you, and stuff like that. He didn't have a whole lot of friends. So I think that plays a huge part too. Like these things you can be predisposed to, but how are you utilizing what you do have to almost protect yourself? Like, what are the protective factors? And are you using them?
Right. So addiction can lead to trauma. Trauma can lead to addiction. So can you share like what are some common addictions that you see, and what are some addictions that people don't think is an addiction?
Yeah, great question. The biggest one, obviously, that comes to my mind is eating disorders. I mean, eating disorders in itself, if you really break it down, is an addiction of the food that you consume, and or how you may get rid of that. Um, so, so that is sort of the biggest addiction that comes to my mind, but there's so many out there. Um, some people have addictions to like, being in the sun, like some people have addictions to, video games. Some people have, that's a little bit more known. People have addictions, gambling is another one. These are all things that people get some type of pleasure from, which is why they continue to keep doing it. It hits that dopamine center and it's like, okay, like I need to keep doing this thing. And now I need to keep doing more of it so I can continue to feel that good about it. And so then you may be thinking, well, eating disorders, like, how does that make a person feel good? Well, I mean, if you think about it, yeah, if you're restricting your food, if you're purging, if you're over exercising, that immediate action may not feel good, but it's like the after effects of, okay, I did this good thing for myself because they perceive that they're doing something that makes sense, that's good for them. So, it may be hard to see why that would feel good to people at first because the action of, purging is unenjoyable, but they're getting something from it, which is why they continue to do it. They get that good feeling afterwards.
We'll see it a lot in our setting where no one's really addicted to broccoli, right? They're always addicted to these hyper-palatable foods, the chips, the cookies, the pasta, and it's usually things that really doesn't require them to chew very much, right? So it doesn't require you to chew very much. Eat more of it. There's a miscommunication between the brain and the gut saying that you're full. So when I'm dealing with somebody who has an addiction to food like that, I'm like, well, just don't buy it. Nobody buy it. But that's not always easy to do.
Right.
So do you have any a person you do who's like the reaching for the cookie? It's usually stress.
Yeah, because the thing with binge eating, or again, just overeating in general, the whole entire process is enjoyable to them, right? So it's not just what you're saying of consuming the food, but like, I've worked with individuals with binge eating disorder who take pleasure in the going out to the grocery store and the purchasing of those things. So if you're saying to somebody, wait, don't do that part of it, like that's almost impossible because that's basically saying, well, get rid of your eating disorder, right? Because that's part of their enjoyment and how they prepare everything for what they're going to do. So instead of maybe something like that, I would maybe like work with them on changing their routine, right? Don't even talk about the food shopping, what you're doing. Like, let's maybe get some activities planned at night, if that's when you tend to do these things. Let's try to be proactive to maybe plant some support, like, or change your routine or add something in that gives you pleasure, so that you don't sort of fall back to the routine of engaging in that eating disorder.
It's easier said sometimes, right, for a lot of folks.
Yeah.
Especially like nighttime, watching TV, scrolling.
Right.
They want you to eat, and it's just mindless eating. It's not even their hunger.
Right.
It's just like
Yeah, routine.
not even thinking about it. So where do you feel food relationships or unhealthy relationships really begin?
Yeah, they can definitely begin at any time. However, I would say a lot of it does trace back to childhood and just things that were going on in the house revolving around food. If again a child is sitting in front of the TV and the parents keep giving them snacks, it's this mindless eating that we're talking about that can occur at a very young age, and they don't really have the wherewithal to know what they're doing or that it's not healthy, right? So a lot of this stuff does develop during childhood, but it could also develop at any point. I've worked in a university setting, and that can be a huge triggering time for people because they're independent, they're on their own, and it's like, wait, how do I manage my meals? Or like, do I have enough money to get these things? And so that's a huge point where we see eating disorder percentages increase. We also are seeing it a lot in adults who are older, who are retired, who, again, it's like a shift in routine. Um, and they might turn to unhealthy eating, whether it's restricting, whether it's binging, whether it's something else. You think of the big life changes, and that's where you typically see a lot of the increases in eating disorders.
And is there
And
a
is there a
clinical
clinical
definition for an
definition
eating
for an
disorder?
eating disorder?
Good question. You know, the disorders are so different, but basically, it's all of them concern a manipulation of food intake. So I think to make it very general, an eating disorder is somebody manipulating or controlling their food intake, um, you know, for some gain for them, if that makes sense.
Okay.
So
Okay.
yeah, I don't know that there's a clinical definition, but that's what I would say. That if somebody's having an issue and they're trying to manipulate what they're eating or what they're doing after they're eating in regards to the food, then we're talking about an eating disorder.
Okay. And
Okay.
what are
And
some
what
of the
are some of the
signs of an
signs
eating
of an
disorder?
eating disorder?
Yeah. Um, I think it really depends based on which eating disorder it is, but there are some that are in common. So, if we're talking about individuals who, avoidance comes into play a lot. So if you have a friend or somebody who's always excusing themselves, maybe from going out to dinner with friends, or sort of doing those things, again, that doesn't equal eating disorder, but it's an eating disorder behavior where you're trying to avoid being out with other people that are eating because you tend to want to just do it in the comfort of your own home or where you are so you can manipulate what you're doing. So if somebody's avoiding, if somebody's hiding food, that's another thing. That occurs very frequently with binge eating disorder, where individuals will hide food in their bedrooms, stuff like that, to have easy access, but access by themselves that nobody knows about. Um, Other things, in common, really, there's typically a self-esteem, self-image component. Now, I wouldn't say 100% that's the case, but that's that's definitely something. If somebody has low self-esteem, low self-confidence, low, not a great image, great body image, that's going to be something that could potentially trigger an eating disorder.
Okay. And what are some of
Okay. And
the
what are some of the
eating
eating
disorder
disorder
symptoms
symptoms
that
that
are kind of like,
that are
oh, I
kind of
did
like,
not
oh,
know
I
that
did
was
not
an eating
know that?
disorder. So we can get,
So
eating
we
too
can get,
much,
eating
eating
too
too
much,
little, hiding food.
hiding food.
What are some other
What are
ones that are
some
like,
other ones that are
oh,
like, oh, I
that person needs some
that
help?
person needs some help?
Yeah. So the first one that came to my mind is there's a lot of people with eating disorders do food rituals, right? And so there are things that they may do with their food, um, that is not the norm, but it's also very difficult to notice potentially. So, for example, having to cut your food into 20 pieces before you eat it. Or, you don't use certain utensils when you eat. These may not be things that are easily picked up by people, but there are these rituals that people, and it almost seems like obsessive compulsive behavior. It's these things that people have to do with their food in order to either feel comfortable actually eating it or they're delaying the process of eating it. Okay. So that's the first thing that comes to my mind that a lot of people do, and it's definitely a symptom of an eating disorder when you're doing some of these things with your food, that other people may not do. um, Trying to think. So other things that you might not notice as an eating disorder, there's something now called ARFID. It's ARFID, and it's avoidant restrictive intake, food intake disorder. This is a relatively new diagnosis where individuals, and it's typically a sensory issue. So people may say, well, I can't eat that food because I don't like the texture of it. I can't eat tomatoes because I can't stand eating seeds or whatever it might be. This is now an actual diagnosed eating disorder where people will avoid large, not even food groups, but just random foods because of a sensory sort of component. Like they don't like the skin on something, and like all of that. So that before was never really recognized. It was just like, oh, maybe that person's a picky eater, right? Or they just don't like that particular thing, and that was a little bit more accepted. But we're seeing more of that being an issue for people, where you know because of that, and then they also then have the fear of like, oh, am I going to gag on this thing because I'm eating it? So it's a whole thing, but that's been, something that's newer that, people should know about. That like, if you're really struggling with the texture, the sensory um, experience when you're eating certain foods, like that can lead you to completely restrict a lot of things, and that could lead to malnutrition.
And we have
We
patients
have
that say
patients
that.
that do that.
Don't like the
Don't like the
way
way
guacamole feels,
guacamole
don't like
feels,
the way
the
hummus
way
feels,
hummus,
um,
um,
the crunching
the
of nuts,
crunching of nuts,
you know,
Yes.
but it has to be
but it has to
learned
be
somewhere.
learned somewhere.
How does that
How
happen?
does that happen?
Yeah. Yeah. I imagine, like, I'm thinking of, somebody that I used to work with, where there were only certain things available in the home. So this particular client, would have access to all of these or certain things. And then later in life, when they were exposed to like other kind of textures of food, they were like, nope, it was like rejected, so I think it does have a lot to do with like when you're young, like what do you give your child? Like what access do you have? Like, if a child likes a certain thing, are you trying to get them to expand, their taste really, or are you just sort of giving the child what they want and what they're used to all the time? I think that could be, something that triggers this type of thing. Um, or completely away from that, a lot of people may have one bad experience with a food in particular, and then they're like, okay, no, I'm not doing that again, for fear. Again, that's where the anxiety comes in, for fear of, I may gag, or I may vomit, or I may, my stomach may not feel well. And that's where some of the stomach stuff comes in too, is people tend to take one or two bad experiences and then put that label on it of, okay, I can't eat that thing. I can't eat that food. I'm not going to do that because I don't want to put myself through that.
And we'll see that
And
in
we'll
our
see
world
that
where
in our
somebody
world where
can't
somebody
eat a
can't eat a
certain
certain
food group, like
food group,
foods
like
that have
foods that
gluten.
have
And
gluten.
once we
And
get
once we get the
inflammation under
inflammation under
control,
control,
and get the
and
gut
get the
kidney
gut
down, we
kidney down,
can
we can
reintroduce
reintroduce
gluten, and
gluten, and
sometimes they do
sometimes they
really
do
okay
really
with it
okay
now that
with
the
it. Now
bile
that the
is
fire
control.
control.
So when we're
So
talking
when we
about
talk
what
about
people
what
eat
people
and not
eat,
eat,
not eat,
what has
what has
been
been
your history
your
with,
history
does
with,
this
does
fall
this
to
fall
one
to
group
one
versus
group
another
versus
group,
another group,
males
or
versus
males versus
females, older,
females,
younger?
older, younger?
What's eating
What's
disorder
eating
like
disorder
in
like
your
in
country?
your country?
Yeah. So, firstly, like eating disorders have always been considered a female disorder, and I think that's wrong. You know, eh, I feel like there's a lot of pressure on men these days. Um, Again, and this will also go into other countries too, but the social media stuff where men are sort of expected to look a certain way, look in shape. The more muscular sort of build is preferred. So I feel like, unfortunately, men are really like overlooked here, because there are ideals of what men want to look like, and so they may restrict. They may overexercise, which is what I was just talking about, to try to get to that. So whereas this was always considered like a female thing for so many years, like I'm finally glad to start seeing that there's more facilities opening up that treat men too, because it's a huge thing. And to go to your question about other countries, the more westernized the country is, the more you're going to see the eating disorders. There's that correlation there. So, like, you look at China, Japan, um, Russia was high up on the list of individuals with eating disorders. I think France was up there. Like the more, I would say, urbanized, westernized countries have that sort of increase in the eating disorders because they have more access. The more access people have to social media, to um, stuff like that, that kind of tell you what you should look like, that's where you're seeing the eating disorders. So other countries, absolutely. A lot of the Asian countries have a significant amount of eating disorders that happen. And that's because of their access, really.
I didn't know that. Interesting. So
So
when we talk about eating disorders, we're talking about body image. And you're right about the men. I mean, growing up, I was overweight. Until about 10th grade, then I went into everything I can to not be overweight and be teased and bullied. It sticks with you, you know, so I feel the internet does not help anyone. I think it's just false. Many things are false in there. It does not help with the body image. So in your practice, in your experience, how young are you starting to see this body image issue?
Yeah, when I worked in an outpatient nonprofit, I saw an eating disorder at, the girl I think was maybe 7 or 8.
God.
And that was the youngest that I had seen. But we're seeing it earlier and earlier now. Like it's, again, I go back to the access thing of, if parents are letting their young children on these social media sites, everything is out there, and everybody is getting the praise for looking thin, or all of this stuff. All of those people have all the followers, and who doesn't want to be popular, right? So then these young females and males are looking at these individuals and saying, okay, well, that's what I need to be like. And from a young age, like think about, like, the brain's not fully developed at that point, so they're not maybe able to really reality test so much there. And they start to sort of engage in these things. And like they're talking to their peers about it, even at young ages. So, I would say by, like, I don't know, third, fourth grade, like you're starting to see some of these things that we didn't initially think was happening until much later.
So is this best to mitigate by getting into the schools now?
What's that?
Is this best to mitigate that process by getting into schools, as a counselor, and you talking to children, third grade, fourth grade, fifth grade now,
Yeah.
before it actually sets in?
Yeah. And what's interesting is actually, my daughter is school age, and they have now actually built in a health and wellness special, or like it's in their cycle of classes that they get. So, once a week or once every, 6-day cycle, they have a health and wellness class where she's actually told me that they talk about, like, like eating, how you kind of feel about your body and stuff like that. So, I like that idea, and I think it has to happen. The sooner you start having the conversations, the better. Even if they're really young, start having the conversations about food. What is food used for? Food is energy. Food helps you. Like, let's start to have a good relationship with food from the get-go, rather than allowing social media to dictate what kids know.
I agree. So when we talk a little about that, you work inpatient too, correct?
Yes.
Okay, so how do we know when it's time for a person to go inpatient versus outpatient? And what do you look for when you're treating them? What kind of progress are you going to see for them to go inpatient?
Yeah. And this is a very, it's a subjective sort of thing here. But what I would say is, um, anorexia has the highest mortality rate. So I'll start with that. So, when we're talking about anorexia and we're talking about higher level of care, we're talking about, obviously, somebody who's low weight. The DSM changed their criteria the last go round, to basically say somebody who is low weight, and they didn't specify a percentage. But when you hear about eating disorders, a lot of the times you will hear about percent of ideal body weight, IBW, or you might hear BMI. I prefer IBW, but if somebody is, underweight, and they're restricting their calories to like, I would say somewhere between like 1,000, somewhere around that or lower, we're talking about a problem, because at that point you're going to be losing weight continuously. We're also talking about somebody needs a higher level of care if there are medical concerns. With anorexia, heart rate is a huge thing. So bradycardia, like if your heart rate is low, we're talking about the fact that not eating is putting that pressure on your heart. So and really across the board, anytime there are significant medical factors involved, those need to be closely monitored, in a hospitalized setting, whether it's a residential setting or an inpatient facility, because you don't want to mess around with those things. You don't want to mess around with heart issues. You don't want to mess around with electrolyte imbalances, because when you start refeeding your body goes out of whack because it's not used to it. So you need to be medically monitored. So I would say the first thing is those medical things I just mentioned. If those are off, without a doubt, I'm looking at somebody that needs to be medically monitored, and that means inpatient. With anorexia, like I said, low weight, we're talking, it depends, on what the person's weight is, but, we're talking about somebody that is pretty significantly underweight and has no motivation to change how much they're eating. If we flip over to bulimia, it's concerning to me when somebody is purging on a daily basis. If somebody's purging weekly, maybe you can work with that person in an outpatient setting. If they're doing something where they're vomiting multiple times a day, daily, like we're talking about the fact that we're going to get some medical problems really quickly if you don't already have them. So I would say all in all, to answer that question, what I go off of most, which I think is so important with eating disorders, is as a therapist, having a relationship with their doctor so that you know what's going on. Because medical issues are the reasons why these individuals pass away. That's why they're so fatal. So if there are medical concerns like electrolytes, potassium, sodium, those things, and heart rate, those are no-brainers to me, that you need a higher level of care to be stabilized. And also too, when somebody's dealing with an eating disorder, their cognitive functioning is not what it would be. So they need to get stabilized. Otherwise, they really can't do the cognitive work either.
So in clinic, is it like you have to eat?
In a facility?
Mm-hmm.
Yeah. So residential settings are pretty much where, you have a meal plan, you're basically observed most of the time, and there's a medical staff on hand. When you're in a hospital, they can insert a tube if they need to. It's almost right. In a hospital, it's like force feeding. In a residential facility, it's like a tiny step below that. But there's expectations there too. So yeah, the worse it gets, the more likely somebody's going to be in a hospital with some sort of tube to feed them.
So you're having in-house therapy as well. Do they bring the family members in too?
Yes. Yeah. So at the place that I worked, they did family therapy typically weekly, as well as multiple individual sessions a week.
Gotcha. So they're doing better. They did what they were supposed to do, and now they're released to care. What is the return rate? Percentage like, hey, it worked for a while, and then right back.
It's high. There's no way around that. I don't have the exact percentage of relapse rate, but when we're talking about the fact that this is an addiction, just like alcoholism or drug addiction, oftentimes it takes multiple treatment attempts in order to get well, because this is a learned behavior. Eating disorders are a coping mechanism. They're your go-to of when you can't manage your emotions, when you're distressed. It's like that's your go-to thing. And when you're taking that away, if that person is not adequately given something to replace it with that they value enough, they're going to be right back where they were, or if they don't have the family support, same thing, especially for teenagers or people that live still or live with somebody else. If they don't have that support, then they fall back into the eating disorder as, again, like I said, a coping mechanism.
Now, is this usually covered by insurance? It's always the biggest question. Like, do they need to be admitted and stuff like that?
It usually is, yes. Yeah, insurances will cover hospitalizations and residential treatments. Now, again, most plans, there might be a deductible involved or something like that. But yeah, insurances do cover these types of things.
Gotcha. Well, what do we return back to the body image? So you're seeing this both in men and women.
Yes.
You're seeing this at younger and younger age. So what kind of resources can you share with us to help those who may be covered by images move away from those negative things about themselves?
Yeah. So, body image is a huge component. And I like to explain it to people as like, it's almost like you put on a pair of sunglasses and you're seeing yourself differently. And then everybody else around you is seeing you without the sunglasses, So I kind of use that to explain to people that, your brain can kind of make you see certain things, or it makes you focus on certain things. Like there's also a disorder called body dysmorphia, where individuals focus on a particular aspect of themselves. So maybe my nose is too big, or what have you. And so the brain, it's almost like the brain's playing that sort of trick on you, and you need to kind of sit there and say, okay, like I understand that this is what I'm seeing, but it may not actually be the reality of what everybody else sees. It's a very difficult thing for people to grasp, but I use that sunglasses thing to tell people, like, this is what it feels like. It's a different experience, so to work on like body image and stuff, I like in therapy, it's a long-term thing. Like I work with body image and work with people with body image issues for years and years and years, and it's not, let me be positive. That's not always the right approach to take of like, if you're telling somebody to say, oh, I'm beautiful the way I am, like that might not resonate with them. Like I take more of a realistic approach of like I said before, like, let's think about what your body does for you rather than necessarily, the outward appearance. Like, your body is this vehicle that allows you to do all of these things, so, let's take away the value in what your nose looks like, right? Because let's take your body as a whole and like, what does that do for you? I've learned that you can't tell people like, oh, you look fine, or, oh, don't worry about that, or, that just doesn't tend to work. I think taking a more realistic approach of like, if you feel that way, like, okay, like understandable, let's maybe challenge that a little bit to get to a better place with that. But what else can we focus on about you, or even about your appearance that like you do like, or you do feel satisfied with?
And do you ever feel like you're just pushing the boulder up the hill? I mean, you're almost fighting against all the messages coming through social media.
It is, yeah.
It's got to be hard.
It's hard. I mean, body image, even just self-esteem work as a clinician is really hard because, you want the person to develop that internally. You don't want them to be taking, all the external stuff and then making a judgment about themselves. Like you want them to develop those positive feelings about themselves, but it takes time. And they also need to distance themselves from the things on social media that are making it worse, and again, social media is an addiction in itself. So that's hard too. And that's why I'm saying like self-esteem work, body image, a lot of them, they go hand in hand, and it's going to be, for some people, a lifelong thing that they work on. For others, it's going to take a lot of time. But I would say focus on being realistic, not being negative or having to be overly positive. Like let's come to some middle ground.
And do you have any suggestions for moms and dads with young kids with respect to how much social media they should take?
Yeah, I mean, I would say monitor what, if you're going to allow kids to be on these sites, monitor what they're on. I mean, there's easy ways to do that, to monitor content on TV, social media, everything. Like there's a lot of good stuff out there, but there's a lot of bad stuff. So I would say monitor what your child's doing. Now again, once they get into high school, you do allow more independence and whatnot. But these messages start from an early age. So whether your child is 5, 6, 7, going up from there, like just know what they're doing, and make sure that they are monitoring the content. There's a lot of good stuff and appropriate stuff for kids out there too.
Excellent. So you shared a lot of great information. I know we have a window to work in tonight. So can you share with us how this may work with you? How can we get in touch with you?
Yeah, absolutely. So I would say the best way to contact me would be through hopestreamcounseling@gmail.com. You can visit our website. It's hopestreamcounseling.com, and you can read some information about me. We also have our phone number on the website, and you can pretty much do schedule a 15-minute consult, which is free, just to chat with me and talk through what might be going on for you, whether or not we might be a good fit. But that would be the best way to reach me. I do have availability currently. So yeah.
Cool. And aside from eating disorders, what other focus do you have in your practice?
Yeah. So eating disorders, like I said, I do work with trauma that's not based, or is not linked to an eating disorder. So I do work with trauma of any kind. I also work with anxiety. Another interest area of mine, being a former athlete myself, I do like to work with athletes who have issues in any area. And how these issues might impact performance and stuff like that.
I can share from an athlete perspective, when I work with men, especially as they get older, they often apply their exercise routine when they were 20 and they're now 25-year-old individuals.
Yes.
We say, or if they're injured, right? We'll see if there's injury and they used to be able to do that. Just physically, emotionally, everything.
Yeah. And I think too, once you give up your sport, there's also a lack of purpose there. There's, like, what am I devoting my time to? And like you're saying, like people tend to want to do the same workouts and do all of that stuff. And it's like, it's not sustainable, So that's definitely an area that I'm interested in working with as well, because I do think it flies under the radar there a little bit in terms of, there's not a lot of sports psychologists out there. I'm by no means saying that I am one. I just, have a lot of interest in that area, and working with those particular issues.
And if you could share a resource, a book or a snippet regarding eating disorder, any suggestions?
Yes. Yeah. So this is not something that I've read yet, but this is something that I've been looking into, and it looks like a great resource, and also speaks to what we were talking about today about males sort of being underlooked, right? So the book is called Please Eat. It's a mother's struggle to free her teenage son from anorexia, and it's by Bev Maddox. This is something that I've been eyeing for a while, but it basically is a mother's recounting of her son's anorexia, and how, she doesn't know what to do. Like, do I force him to eat? How do I do this? And worried that her son's going to die, So that is something that I'm really looking forward to reading, and so that's definitely on my list.
Excellent.
Other things, if you want eating disorder resources, there's tons of free trainings out there geared towards various professionals. So the Renfrew Center has a bunch of stuff on their website. Take a look at those. They're free. They're geared towards different populations. And there's just the National Eating Disorder. There's a website there, NEDC, that also has a ton of resources. So hopefully that's helpful.
Great. I really appreciate your time, though. Thank you so much.
Yeah, thank you so much. I
This
appreciate
is
it.
a lot of fun. All right, so everybody, this is Dr. Monk here from Care Functional Health, and if you have any questions, please feel reach out to us.